They called it God's own medicine. The first time it dripped into a human vein, fever broke, pain vanished, and the feverish mind whispered gratitude to chemistry itself. The year was 1805, and a young German apothecary named Friedrich Zerturner believed he'd captured the divine principle hidden inside the poppy. He had isolated a crystalline compound stronger than anything nature had ever offered. He named it morphium, after Morpheus, the Greek god of dreams. Scientists applauded him for transforming crude opium into science. They didn't yet know that he decreated the first modern narcotic and the first chemical that would turn healers into the sick. Through the 19th century, doctors were heroes armed with morphine. The world was full of pain, wars, childbirth, surgery without anesthesia, and suddenly relief sat in a vial. Morphine worked where faith ended. By the 1850s, physicians carried it the way priests carried holy water. The newly invented hypodermic syringe allowed direct injection, bypassing slow digestion. A single prick and agony dissolved into euphoria. In an age when infection, gangrene, and amputations were routine, this felt like salvation. But salvation turned out to be habit. The first victims of morphine addiction were not criminals or drunks. They were the physicians who administered it. Doctors used it innocently, at first for migraines, toothaches, menstrual pain, coughs, and insomnia. Patients wrote poems about its kindness. Civil War surgeons injected soldiers in trenches and later themselves. Chronic pain did not discriminate, and neither did dependence. The statistics disappeared in official reports, disguised under polite medical Latin, but privately journals whispered that 15% of American physicians in the 1880s used morphine daily. Some called it the doctor's disease. A Kentucky surgeon famously wrote, "I would rather part with my practice than with my syringe." The tool that connected medicine to compassion now kept its keepers chained. By the 1870s, towns across Europe and America carried quiet epidemics of morphinism. Because physicians held privileged access, their patients followed. The pattern spread the way knowledge usually does. Down the social ladder by prescription pad. The same chemical used to save lives in childbirth found its way into patent medicines, children's cough elixirs, even teething powders. Names like Mrs. Winslow's soothing syrup and Godfrey's cordial-lined pharmacy windows, each dripping with morphine or laudanum. Mothers gave it to infants for quiet nights. Some babies simply never woke again. And when the addiction crisis could no longer hide behind euphemisms, pharmaceutical optimism offered a new miracle: heroin. In 1898, the German company Bayer, searching for a way to detoxify morphine, acetylated it twice and produced diacetylmorphine. Laboratory tests showed it was 10 times stronger, yet, paradoxically, less habit-forming. Doctors believed it could cure morphine dependence. They prescribed it to addicts as treatment. For a few months, it worked. A brighter rush, smoother withdrawal. Then tolerance came, and the craving multiplied. Newspapers called it the heroin of medicines. The irony wrote itself. The chemical had learned to change costume without changing nature. Hospitals filled quietly with lost healers. Case reports describe surgeons injecting between operations, anesthetists collapsing after procedures, family doctors dosing themselves before house calls. The profession's secret shame hid in plain sight. Prescriptions written to aliases, or to clinic stock, which could never run dry. Addiction hid behind the authority of the white coat. Patients could not accuse their saviors. It would take half a century before the first honest phrase appeared in print: occupational narcotic addiction among physicians. Some sought cures through other chemicals. One Chicago physician in 1915 used cocaine to wean himself from morphine, then morphine to taper off cocaine, dying halfway through the circle. Others admitted themselves to sanitariums that promised moral strength over chemical bondage. These hospitals, often run by other addicted doctors, prescribed even more morphine under different names. The industry of self-redemption thrived on relapse. By the Prohibition era, morphine's reputation had turned from divine to diabolical. Yet pharmacies still sold it over the counter in some countries. Civilians addicted were pitied. Doctors addicted were quietly transferred, sometimes promoted to administrative work where they could hide their tremors behind paperwork. In 1914, the United States passed the Harrison Narcotics Tax Act, the first attempt to regulate opiates nationally. Ostensibly a taxation measure, it criminalized prescribing narcotics for maintenance, forcing physician addicts underground. Many surrendered their licenses, others forged papers and carried on. The federal government had transformed a medical dependency into a moral crime. Patients lost legitimate access, and black markets bloomed overnight. Street opium dens multiplied while legitimate addicts, many of them ex-doctors, disappeared into them. History would repeat the pattern indefinitely. Regulation, substitution, resurgence. When chemistry advanced, it didn't abandon morphine's principle, it refined it to precision. In the 20th century, synthetic opioids arose: methadone, oxycodone, hydromorphone, fentanyl. Each claimed to be the safe evolution of the last. Each silently harvested new dependents, including the very professionals managing the crisis. Internal addiction monitoring programs within hospitals report the same paradox. Physicians addicted at roughly the same rate as the general population, but with higher lethality. They have purer access and a deeper ability to rationalize risk. No one questions the hands holding the scalpel. In the 1980s, anesthesia departments began confronting another wave, the rise of fentanyl dependency among anesthesiologists. The drug's euphoric onset was measured in seconds. A few micrograms stolen from anesthetic syringes, unseen, unrecorded. Colleagues noticed mood shifts, light tremors, unexplained absences in the call room. Some survived after mandatory rehab. Many did not. Studies in medical journals record the pattern with sterile phrasing. Fatal self-administration in clinical setting, disposition, deceased. Behind each line hides another brilliant physician whose education outpaced his humanity. Why doctors fall is complex but brutally logical. They live inside pain, their patients, their own. They know pharmacology intimately. They believe they can dose safely. The same confidence that lets them cut open bodies convinces them they can manage pleasure chemically. Some start to understand addiction as an experiment they can reverse whenever they choose. They trust half-lives more than humility. The poppy, patient, and indifferent proves each wrong. By the early 2000s, the opioid epidemic that gripped the general public had already run rehearsals in hospital locker rooms. Pharmaceutical representatives once again promised miracles masquerading as improvements. The slogan, "low abuse potential," appeared in brochures for OxyContin. Sales targeted physicians first. The profession most wary of addiction became its own advertisement. Between 1999 and 2020, nearly 500,000 Americans died from prescription opioid overdoses. Among them were thousands of health professionals. Emergency physicians found in call rooms, nurses collapsed in supply closets, dentists overdosed at home after hours. The cycle that began with Sir Turner's experiment in 1805 still hadn't ended. The names changed, the chemical script did not. Medical boards now run confidential recovery networks known as physician health programs. Their mission is simple: save the healer before the public knows he's broken. Success rates are high, but the secrecy sustains stigma. Most relapses occur when doctors return to the same environment that first provided access. One anesthesiologist described the sensation in a documentary interview before his death. "It is like carrying a loaded syringe in your soul. You keep telling yourself you won't press the plunger, until you do." In academic libraries, bound in dust, the journals still record the same story under new diseases. Morphinism became opioidosis. Addiction became substance use disorder. The vocabulary modernized, morality softened, but the biochemistry never forgave. The reward pathways burned by opioids remodel the brain's deepest survival codes. Error correction itself becomes corrupted. After prolonged use, neuroimaging shows decreased activity in the prefrontal cortex, the region that calculates consequence. In poetic terms, the mind that once could amputate a leg to save a life can no longer amputate its own desire. There is a ritual irony in medicine's relationship with narcotics. The profession that teaches first, do no harm, built its modern identity on a drug that defines harm itself. Morphine taught humanity to fear pain less, but in return demanded permanent reverence. Its children, codeine, heroin, fentanyl, still sit in hospital cabinets beside the names of saints and donors. Every opioid syringe dispensed in an ICU is double-checked by 2 nurses, barcoded, registered, refrigerated, guarded like holy relics. Yet the system's builders remain vulnerable to their whisper. No other profession keeps temptation so close, so necessary, so legal. Not all stories end in autopsy tables. Some doctors survive and turn their collapse into compassion. Narcotics Anonymous meetings across major cities often include small clusters of lab coats in the back row, listening rather than leading. Their testimonies break crowds. The surgeon who injected between patients, the obstetrician who missed a delivery while unconscious, the resident who forged signatures until confronted by colleagues. Each describes the same descent disguised as dedication. Just enough to relax, just enough to work longer, just this week. Addiction doesn't feel like rebellion to them. It feels like efficiency. The chemical that turned doctors into addicts didn't seduce them with pleasure. It seduced them with productivity. Regulation grows stricter every decade, and yet deaths persist. Synthetic fentanyl, now 50 to 100 times more potent than morphine, flows from clandestine labs worldwide. Even seasoned toxicologists struggle to handle it safely. Micrograms absorbed through skin can arrest breathing in seconds. The boundary between clinician and corpse has never been thinner. The profession that invented resuscitation must now keep resuscitating itself. And tonight, somewhere under blue hospital lights, a young doctor adjusts a dosage at 3 a.m., the smell of antiseptic and latex thick in the air. His fingers hesitate over a vial labeled hydromorphone 2, M green ml. He knows exactly how it works, what it does to synapses, what it will do to him. The syringe gleams like understanding. Maybe he pauses, maybe he doesn't. The chemical waits either way, patient, precise, eternal. The cycle continues in whispers and autoclaved rooms. Regulations exist, knowledge exists. What's missing is immunity to temptation, the one condition medicine cannot synthesize. If this story unsettles you, it should. Share it, talk about it, remind people that beneath every cure lies the seed of its opposite. The chemical that turned doctors into addicts never really left. It just keeps changing uniforms, and every generation of healers still believes they can control it until the plunger moves.